Hello, I'm Sasha Herring, retrieval nurse practitioner at the Evelina Children's Hospital, and I want to talk to you today about the challenges of managing hyper-inflammatory shock in children during the COVID-19 pandemic. This is very much a reflection on our experiences in the Evelina. So the first thing I'm going to do is just give you a little bit of context, tell you about our nurse practitioners, show you where the Evelina is. Spend a little bit of time talking about hyperinflammatory shock and what it is. And then I'll just talk about my personal reflection on why it was so challenging for us as advanced nurse practitioners. So this is the Evelina. You can see some London landmarks there. We've been around for a very long time, but you'll be able to see that we're just there on by the Thames. It's a building built onto the back of St Thomas's Hospital. And we moved to that building in 2005, although the Evelina itself has been around, as I said, for quite a lot longer than that. So retrieval nurse practitioners at the Evelina Children's Hospital, our program started in 2003, and we were the first ANPs to work in retrieval in all of Europe. There were similar programs in America, but we call ourselves RNPs, retrieval nurse practitioners. So we're primarily responsible for assessing, stabilising and transferring acutely unwell children from one location to another. And that's usually from a district general hospital to a tertiary paediatric intensive care unit within the South Thames region. We're registered as non-medical prescribers, and most of us have completed our masters at London South Bank University, and those who haven't yet are working towards that. We've trained ANPs and RNPs for other institutions through the same courses as I did, and we've currently got 84 ANPs who have completed the program, which is pretty impressive. And just to show you a little bit of context about what it is that we do and our numbers, our service receives quite a lot, over 1,500 referrals a year, and most of these are by telephone. And about half of those usually result in what we call a retrieval, so a transfer of a patient back to a tertiary intensive care. And you can see that numbers have been pretty constant, 2017 to 2019. But then in 2020, we had a significantly quieter year for referrals and for retrievals. You can see in the column that talks about how many of those have been led by RNPs, that number's sort of fairly constant up until last year, where we did a larger proportion of the retrievals. So essentially, our service requires us to have 2 retrieval teams available 24 hours a day, 7 days a week. Usually one arm of that rota is led by retrieval nurse practitioners, and the other arm of the rota is led by our middle grade doctors. During the COVID pandemic, a lot of our middle grade paediatric doctors were actually redeployed into adult COVID areas. And so the retrieval nurse practitioners took more of the burden of transfer of patients during that time. But you'll see also that we appointed 2 more RNPs into post at the beginning of that year. So combined with fewer doctors, we also had more RNPs, which is, I think, the explanation for why that number is slightly higher. I just want to show you this graph that tells you about the disease profile of the children we transferred. And you can see that actually it's fairly static. I don't know if you can see my mouse here, but it's fairly static through 2015 to 2019. The bulk of our retrievals are children with bronchiolitis. And then in 2020, that number dropped from 350 down to 100. So that was extremely significant for our service. And that's basically because everybody was in lockdown. They stayed at home, the children didn't go to nursery, they didn't share their respiratory viruses, and they didn't become ill. Also, you might see the significant increase of children with sepsis. Now, this is the group of children that I'm going to talk to you about. These are the children with a hyperinflammatory shock syndrome. Not all of them, but the reason that that number has climbed so much is because of this new phenomenon that we started to see. So I think this is the first publication about hyperinflammatory shock in children during the pandemic. And I've just, there's a little timeline here that comes from one of my colleagues' papers. The first cases that we noted were in mid-April, over a 10-day period. We had 8 children who were referred to our service with these unusual presentation of hyperinflammatory shock. It looked a little bit like toxic shock syndrome, and there were some similarities to Kawasaki syndrome. But actually, the children presented to 2 different hospitals, which were in a very close geographical area. And it was then that our team started to think that there was something funny going on. So you can see also on the timeline that very soon after that, towards the end of April, there was an NHS England alert issued nationally for people to be aware to look for these children presenting. And very, very quickly, the Royal College of Paediatrics and Child Health issued some guidance. That was in the first week of May. And our letter to the Lancet here was published, I think, in the second week in May. And it detailed the 8 children who had presented and gave quite a lot of detail about their ages, the therapy that they had. So what is it? Well, we're talking about a pediatric multi-system inflammatory syndrome temporally associated with SARS-CoV. So I think probably it's easier to call it PIMS-TS, which is what we call it. In the USA, they call it a multi-system inflammatory syndrome in children. And actually, you'll see both of these terms used in the literature. The case definition of PIMS-TS was the most useful one, I think, is from the Royal College of Paediatrics and Child Health. And actually, I've summarised this definition because it's actually quite long. But the children, they present with persistent fever, inflammation, and evidence of single or multi-organ failure or dysfunction. And many of them had similar features to Kawasaki's disease. And actually, a lot of time has passed now, but even so, now it is impossible to distinguish between Kawasaki's disease and PIMS-TS at presentation. And the other thing that were required for diagnosis was the exclusion of any other microbial cause. So that obviously doesn't happen immediately. It requires 48 hours of blood culture, waiting for blood cultures. But that was one of the exclusions. If children were positive for a bacterial infection, then they didn't have PIMS-TS. And interestingly, some of the children were positive for COVID, but actually the majority of them tested negative. There's a lot of information on this next slide. I'm not going to go through it in detail, but I will just I'll just draw a couple of things to your attention because the laboratory characteristics were quite interesting. But the majority of the patients that we had they presented with no preceding illness or only very mild symptoms associated with COVID 4 to 6 weeks before they presented. Some of them had no symptoms at all, but reported family members who had been COVID positive or had COVID symptoms. And as I said before, the majority of them were COVID negative. Later on, it transpired that the majority of the children were positive for IgG antibodies, indicating that they had had a COVID infection that was obviously asymptomatic at the time. So they presented with a high fever, they presented with low blood pressure, and very commonly they presented with abdominal pain. And this was significant because a lot of the children actually had appendectomies, and then they were referred after the appendectomies had been revealed to have nothing wrong with their appendix. But a lot of the blood markers showed inflammation and coagulopathy. So they had very high CRP measurements, over 300s often. They had abnormal D dimers, high ferritin, and a coagulopathy with a prolonged INR. I won't go into too much detail about that because there's a lot of information in there. So interestingly, the majority of the children were previously fit and well. So very few of them had comorbidities. 25% of them were obese. Now these numbers actually are from a systematic review of the literature. They're not from our Evelina, and we actually did see quite a few children who were significantly overweight, but possibly didn't fall into the obese categories. But also they were more likely to be male, they were more likely to be adolescent, and they were from racial and ethnic minorities. And you can see I've put the number down there. This is how many children we saw at the Evelina up to last month. And those children were either retrieved to PICU by our team, they were admitted directly to the wards from the district general hospitals, and a small proportion of them actually were referred to our ID teams and actually seen in our patients department. I just wanted to show you this slide because it's quite interesting to see how the presentation of the PIMS-TS patients related to the COVID peaks in our trust. And I think we probably could extrapolate this across the UK, but the data I've got is just for Guy's and St Thomas's. And you can see that these are the peaks of admissions of patients to Guy's and St Thomas's Trust. The red line down here is the deaths that we had, and the green line there are the COVID patients. Now the numbers aren't the same. The numbers on the vertical axis aren't the same. But what is interesting to see from this graph, I think, is that the PIMS admissions came at a 3 to 4 week interval after the peak COVID admissions. Just go on to the next slide because I think it is a little bit helpful for you to understand what the therapeutic management of the children was. Now, in terms of the acute management, when the children presented to the district general hospitals, they were in shock. So they required fluid resuscitation, they were given antibiotics, and they were given inotropic support to support their cardiac function and their blood pressure. And some of them were given steroids and some weren't, and that was very institution related. So I think we gave quite a lot of steroids in our South Thames region. In other regions, they tended to be more reluctant to give the steroids. Once the children were admitted to PICU, they were given immunoglobulins. They may have had steroids. They were also given prophylaxis for DVTs and for clotting and for coronary artery clots. And they also were deficient in vitamin D, so they were given vitamin D supplements. So this was pretty much the day what we did at the Evelina. These numbers are again from the systematic review of the literature, which was actually international. And I think the numbers were a little bit different on that. I think at the Evelina ventilated fewer patients, but actually had a larger number of patients on inotropes. And that's most likely because we're a cardiac centre. So the children came to us because they had recognised cardiac dysfunction and needed investigation and management of their cardiac dysfunction. So we had a high proportion of children who needed inotropes. So I guess the crux of this, the talk that I want to give to you is why are the challenges so, why were these cases so challenging for retrieval nurse practitioners? Well, it was very difficult to unpick this actually. The first thing was that because it was a new phenomenon, there was a lot of excitement. I was trying to think of another word, but essentially everyone was very excited about the fact that we had recognised a new phenomenon. There were loads of discussion, loads of multidisciplinary discussion. There were loads of talks inside our hospital, in the region, nationally. We had discussions at our ward rounds. We had loads of emails with lots and lots of data included in it. And actually, a lot of that was quite overwhelming for us as RNPs who were actually dealing with these patients when they first presented. I think that the laboratory markers for these children, a lot of these measurements are common in adults with sepsis, but actually they're not something that we commonly looked at in children's intensive care. So we would have phone calls from doctors at district general hospitals who would give us a big long list of laboratory results, and actually that involved quite a difficult application of well, I had to concentrate really hard, because normally the majority of children who are referred to us, they understanding their laboratory results would be second nature. We have the same kind of children referred again and again. So a lot of these things were different, and that was actually quite stressful. So it was quite stressful, because it would be one thing if we were taking 1 or 2 calls every now and again, but on some days we were juggling 5 or 6 calls at a time from doctors at district general hospitals. So essentially each referral took about a half an hour to take the details of the patient and to give some initial advice, and then each one had to be discussed with the consultant. We would then have to phone back the district general hospital, speak to the paediatrician we'd been speaking to before, give the advice from the consultant, and then decide whether or not the patient required transfer. So each of these calls might have involved 3 or 4 or conversations, sometimes over a 12 or a 24-hour period. And some of these calls came in the night. So we obviously provide a 24-hour service. So we were under pressure to be able to give management advice after hours without having our consultant easily to hand. I mean, all the conversations were consultant-led, but there was a pressure on us to be able to give advice immediately once the phone rang. So I guess also at the beginning of the pandemic, when PIMS-TS first evolved, every single child that was referred, the consultants wanted the children in our institution. So we transferred loads and loads of children who probably, in hindsight, didn't really need to be in PICU. As the year progressed, I'm sorry, I don't know what I did there. As the year progressed, it became quite obvious that this wasn't actually going to be sustainable. And so we started transferring the children to the wards. And actually, the team on the wards were absolutely fantastic, and they manufactured a 12-bedded high dependency unit out of nothing. They had nurses redeployed from other areas, and they employed 2 ANPs to essentially run the high dependency unit. As RNPs working on PICU, we will have a responsibility for those children as well. So they would come into the hospital either brought by us or transferred by the district general hospitals, and then we would have to go and see them on the ward and give advice about acute management. And there was quite a lot of movement of children between PICU and the HDU, and we had a big part to play in that. So that was actually quite a pressure. I think I'll move on to the next slide. The majority of the children who came to PICU and were referred through the retrieval service actually had cardiovascular instability. So they needed inotropes, they needed fluid resuscitation, and they needed inotropes. Very few of them required ventilation. But it was actually the inotropes which required the children to be admitted to PICU. And normally inotropes would be delivered by a central line, but these children were awake. So we had a very interesting clinical dilemma, one that in the past had occasionally occurred, but actually with these children was actually occurring very commonly. Now we did have some experience of giving inotropes through peripheral lines, but and in fact that was under discussion even before the pandemic began in terms of how our practice might change. But in over the course of the presentation of these children, that became much more pressing. It became much more, well, we had to make quick decisions when we were actually on retrieval. Although when I just audited the retrievals and the number of children requiring inotropes for a little project that we were doing, and actually the numbers, if you look at them, only 12 received inotropes. 12 out of 1,125 audited received inotropes other than dopamine only. And I can tell you at the time, it felt like a lot more than that. Each of those children required a great deal of thought, a great deal of discussion, and actually there was quite a bit of controversy. And the controversy was because our consultants couldn't agree amongst themselves how they wanted to change our guidelines. And just out of interest, you might like to know that the guidelines still haven't been changed, and we're more than a year down the road now. So I guess the final thing I just wanted to talk about in terms of the challenging aspects for RNPs was that this was not our usual cohort of children. The children were older and they were adolescents. Now, the majority of the adolescents that we would normally have on PICU would be have significant disabilities, and they'd usually be non-verbal. Actually, our main patient workload is children under the age of 2. So we have few adolescents, and these adolescents were previously fit and well. They weren't ventilated, and so they were completely aware of what was going on around them. Consequently, they were they were completely aware that this is a worldwide pandemic, that they're significantly unwell. They're being transferred to intensive care with an illness that had a very unclear outcome. So they were surrounded by various medical teams, had lots and lots of investigations, uncomfortable investigations. They were scared and they thought they were going to die. And actually, their parents thought that too. So from a nursing perspective, we had to provide psychological support on a much more intensive level than would usually be required for our normal PICU cohort of patients. We had to do that within a context where visiting was limited. And so we didn't have a complete ban on visiting, but we were only allowing one parent to visit at a time. So that meant that they weren't able to be together to support each other at the bedside. Now, of course, knowing what we know now, we were able to tell the parents that children who, and the young people themselves, that children who present PIMS-TS, that actually the majority of these children are completely recovered within 6 weeks. And they are discharged from hospital services by 6 months. So if we had known that then, this would have made a massive difference to how we could provide reassurance to the families, and also, I think, how we felt about caring for these children ourselves. Thank you. That's all I've really got to say. And I hope that we'll be able to facilitate some questions.